All right, so we are discussing about antepartum hemorrhage. So, hi everyone. So, welcome to Medically Us video. So, this is basically I have done a brief description of antepartum hemorrhage, the cause, placenta previa. I hope you all like it. Please do comment in the comment box what all videos you want next for me to brief and so here we go. So in antepartum hemorrhages we can have antepartum uh, we have bleeding, right? The patient, the female, she will come with bleeding and the bleeding will be after 28 weeks and what happens in placenta previa, why is there bleeding? All right, so what is placenta previa? Placenta is lying in the lower uterine cavity. All right, where placenta lies? Normally the placenta, it is in the upper uterine cavity, right? But why is the placenta lying lower uterine cavity? So there can be many causes for that. If a placenta is large, if there are other conditions present, if the endometrium is not good, if endometrium is having endometriosis, if there is previous surgeries which has occurred, C sections and all. So we'll be seeing that further. So what happens is the placenta previa, if the placenta is lying in the lower uterine cavity, low lying placenta is placenta previa. So how will you diagnose that it is a case of placenta previa? So what will you do? You'll go with a scan, ultrasound scan in the third trimester, right? So from there you will get to know that okay, this is the placenta is low lying here. Every low lying placenta will not cause placenta previa, all right? So risk factors are previous history of placenta previa. So in this pregnancy, there is there are increased risk of having placenta previa. If, and second most, if there is history of C-section in the previous pregnancy, so this pregnancy can be having placenta previa. All right. So I was telling you why placenta is lying low, why it is not lying in its normal position. So if the placenta is big, all right, if it can be big in twins pregnancy, if a patient is diabetic, so there can be a big placenta, it's a risk factor. And if it has variations like suction surrogate placenta or placenta bilobata, all right. So one part of the placenta is lying in the lower uterine segment, so it is a risk factor, all right. And previous surgeries such as C scars, these are also risk factors. So if these are the risk factors present, above risk factors, so there are more chances that this pregnancy can be having placenta previa, which is the cause of the bleeding with which patient has presented to us. So she has presented to us after 28 weeks of gestation, and she has presented to us with bleeding. So how will you say that this is a case of placenta previa? Just you are sitting in your OPD or just in emergency, and how will you see? How will you diagnose? How will you come to know that okay, this can be probably a case of placenta previa? So the bleeding, it should be of bright red color, and there should be no cause and no trauma history, and there should be no pain. She has presented only with bleeding. There is no pain, and bleeding should be sudden in onset. All right. How will you differentiate it from abruptio placentae? So abruptio placentae has dark red color bleeding, and pain is present in abruptio. Why is there pain present in abruptio placenta? Due to release of thromboplastin. When the placenta it gets separated off from the wall, from the endometrium deciduobissalis, it releases thromboplastin, and thromboplastin is uterotonic, so it causes contractions and it lead to pain. All right, so what happens in placenta previa? So these episodes of bleeding, these can be recurrent in the same pregnancy if the case of placenta previa. And warning hemorrhages are present in placenta previa. What are the warning hemorrhages? Warning hemorrhages is there is initially there is less bleeding, and later on there will be torrential bleeding. So these are the warning hemorrhages, the initial slight bleedings. So recurrent episodes of bleeding can be present in the same pregnancy, whereas in abruptio placenta there are no recurrent bleeding in the same pregnancies, and there is no warning hemorrhages, because if in abruptio placenta if bleeding is occurring, so it has to deliver patient, we have to take the patient for immediate termination of pregnancy, we have to resuscitate the mother, we have no other option, all right, because patient can land up in DIC, so that requires an immediate action. So on general physical examination, what will you what all findings you will be having if it is a case of placenta previa? So the uterus will be soft, relaxed, non-tender, and the height of the uterus will be equivalent to the period of gestation. Fetal heart sounds will be heard, fetal parts will be felt, and the in case of abruptio placenta, the height of the uterus, it will be more, okay, more than the period of gestation. Why it is more? Because of the blood collection, right? Because in abruptio there is a concealed variety, right? There is a in which the blood gets collected behind the placenta, and it enters in the myometrium, and the entire uterus, it becomes bluish or wine colored. So this condition is Covey layer uterus. Okay, that's Covey layer uterus. So we'll discuss that, not here, but I'm just mentioning the differentiating features so that you can correlate. So if you have to screen whether it is a case of abruptio placenta or placenta previa, you have to do transabdominal ultrasound. And if placenta previa, you have diagnosed that yes, it is placenta previa, you will go with transvaginal ultrasound to check the distance of the placenta from the internal os. All right. We do not do per vaginal examination if it is a case of placenta previa. Why? Because there is chances that when you do per vaginum examination, it can lead to bleeding. So per vaginal examination is contraindicatory, and there are more chances of malpresentation in case of placenta previa because the lower uterine segment is all covered with placenta. So the malpresentations are common. It can be a transverse lie, it can be a breech presentation, whereas the malpresentation is not so much common in abruptio placentae. I will like to add the general examination features of abruptio also. So if it's a concealed variety of abruptio, the uterus will be rigid, tender, hard, tensed, and the fetal heart sound and fetal parts, these will not be easily heard and felt, right? Heart sounds will not be easily heard, fetal parts will not be easily felt. Why? Because uterus is hard, okay, and height of the uterus will be more, I have told you, and there can be a presence of fetal distress in the concealed variety of abruptio. All right, so how will you manage? So for managing the placenta previa, you will be seeing if the patient is having, what is the state of the patient. If patient is stable, she is having no active bleeding, ultrasound is normal, there is no fetal distress, and so we'll go with expectant management, McAfee Johnson's regimen, in which we admit the patient, we'll arrange for blood because we can anticipate the loss. All right, so we'll give RH negative, if patient is RH negative female, we'll give anti-D 300 micrograms. We'll give corticosteroids uh, if she is less than 37 weeks, because to attain lung maturity. We can give tocolytics. All right. Nifedipine we'll give to prevent contraction if she is having contraction, because ultimately we want to carry out the pregnancy till continue the pregnancy till 37 weeks. We do not want premature delivery. All right. If if there is continuous bleeding and patient goes into hemodynamically unstable conditions and there is fetal distress, so we have to immediately stop this expectant management, and we have to go with termination of pregnancy. All right, so we'll go with termination of pregnancy if it is the case of minor degree placenta, if it is type 1a p, anterior and posterior if it is type 2 anterior. Okay, so we'll go with vaginal delivery. We'll try out vaginal delivery. And but if it is a case of major degree placenta previa, we'll go with cesarean sections. Okay, there is no other option, so it is the first choice. All right. Now, what is the degrees of placenta previa? There can be type 1, type 2, type 3, and type 4. In type 1, there can be anterior and posterior placenta previa. If it is attached to anterior wall, it is anterior placenta previa. And if it is attached to posterior wall, it is posterior type 1 placenta previa. So what happens is, if the placenta, if it is lying here, if it is less than 2 centimeter from the internal os, this is the internal os. So we'll say that this is type 1 and anterior and posterior depending upon the wall. But if it is lying here in the margin of internal os, then we'll say it is type 2. And if it is, so it is also known as marginal placenta because it is lying along the margins of internal os. But if it is like partially covering the internal os and the cervix is fully dilated, so this is type 3. And type 4 is when it is covering the whole complete of the internal os and the cervix is fully dilated. All right. So this is type 4. So type 2 posterior, type 3 and type 4. These are the major types in which we have to go for C-sec. All right. So here we learned about the placenta previa. If you want me to discuss on some other topics as well, I want you guys to comment in the comment box if any topic you want me to brief on. So thank you so much for listening me out, and I would like you guys to share this video. Please like this channel and please subscribe it, and do comment what you like in the video, if it is informative, if it is not informative, what all additions you want, everything, every suggestion is welcome. So thank you so much. Keep learning and